My name is Guillermo Escobar, and I'm going to be running the first one, which is hiring an international medical graduate for your residency or fellowship program. What works, what doesn't. I'll begin with a little bit of a background. With regards to international medical graduates, in 1965, within the United States, they accounted for approximately 10% of the U.S. healthcare workforce. By 1981, this had doubled to about 21%, and as of 2011, it's approximately between 26 and 32%. And interestingly, something that's often forgotten is about 1/3 of the international medical graduates are actually U.S. citizens that go to a foreign country to get their medical training and subsequently return. And this is not some characteristic that's unique to the United States, but rather several large developed countries such as Canada, Australia, and the United Kingdom also have approximately 1/4 of their healthcare covered by international graduates. This is out of the Educational Commission for Foreign Medical Graduates website, and it sums up the number of certificates that have been issued since 1988 to about 2012. The larger bars are the total number of certificates, and if you notice in the late 80s and early 90s, it stayed pretty much around 4,000 certificates per year. And then it went up to somewhere in the range of 10 plus minus 1 or 2,000. At the very bottom, if you notice, there's a lower screen, and that's the number of U.S. citizens that got an ECFMG certificate. There's a notable drop here, right around 2000 to 2001. And that's when there was a new requirement to do a clinical skills assessment. And the way the ECFMG worked this out is that you had to be interviewed and do your live patient scenario only in Philadelphia. So anyone who wanted a certificate to come train in the United States had to fly to Philadelphia to do this thing. So there was a marked drop there, both probably by availability as well as other things. And subsequently it goes back up. So the most common country to go to medical school to get an ECFMG certificate was, interestingly, India, by far and away at 15% of the certificates issued. And in 2012, 29% of the certificates were to U.S. citizens. And if you notice, there's this trend that tends to go up over time. And if you zoom in on the top 5 countries of origin where the people had citizenships, most notably the yellow bar, or the yellow line at the very top, are Indian nationalities. However, over time, you start to notice this other blue bar underneath, and that's U.S. citizens that have gotten ECFMG certificates over time. And as of 2010, they've taken away Indian citizens. Anyway, why do people come to the United States to get their training or even to stay? There's these concepts of push and pull, of why leave a country and why to come to the United States. And in a review of a poll that was done for international medical graduates in Canada, they compiled the top 5, and the number 1 was socioeconomic or political situations that sort of drew them in or drew them away. They're concerned about better education for their children, concerns about where to raise their children, or the quality of the facilities or the equipment, and finally, opportunities for professional advancement. As you can imagine, there might be better opportunities in larger countries than where you may be. So with regards to this session, how can you succeed as far as hiring an international medical graduate into your vascular training problem? I need some help. So I've invited 2 people. One of them is Dr. Tassiopoulos, who was born in Greece, medical school in Aristotle University, and 2 years as a flight surgeon in the Greek Air Force. He did a clinical fellowship in Baylor, subsequently general surgery at Upstate Medical University, vascular fellowship at Loyola University, stayed in Chicago in Cook County Medical Center, and subsequently in 2006 went to Stony Brook, where he is now the chief of vascular surgery and the program director. And then my program director for general surgery, Dr. Mark Nehler, born in Portland, Oregon, and subsequently a lifer, both medical school, general surgery, vascular surgery at Oregon Health Sciences, and currently the chief of vascular surgery at University of Colorado and the program director in general surgery. So if you do the math from 1999, sorry, that since 2002, that's when I met him. Since 1999, he's dealt with, is the best word I can think of, over 100 general surgery residents in and out of the program. So please help me appreciate their presence, Dr. Tassiopoulos and Dr. Nehler. So with regards how to start, I I thought I'd ask Dr. Tassiopoulos to begin. As far as some of the stigmas that are associated with international medical graduates are that they might be low outcome as far as passing scores, or that they don't have a good presence, if you will, in the United States because of their previous medical training outside. Is that something accurate?
I think that currently it is not accurate. I think in the past there have been circumstances where people were hired without having a previous presence in the U.S., and that raises a number of issues. First of all, there are some lingual barriers that have hindered these people at performing at their best. And there are some anecdotal stories, some of them even from the institution that I'm at right now, where people presented credentials that were not even valid. So that created an aura that certainly a lot of people wanted to avoid the risk, so to speak, of getting these people in their program and dealing with whatever individual issues they may have. What we're witnessing in the past few years is because all of our programs are so competitive right now that for any foreign medical graduate to be considered even for a position like this, they have to show excuse me, credentials that are way above what we would consider appropriate for the American graduates. So you see applicants that have USMLE scores way in the 250s and 260s. They have already published. Some of them have already done part or all of their training in a very credible institution outside the U.S. And I will give you the example of my current graduate of our vascular residency program, who fully trained in vascular surgery in Brazil. He did 2 years of a research fellowship at the Mayo Clinic. So when this gentleman arrived to start his residency with us, he was absolutely ready to do it. Because of where he started from, he clearly has distinguished himself compared to any other graduate that we've had in this institution. When somebody graduates a straight 5-year program with 25, 26 peer-reviewed journal publications, 7 book chapters, and a presentation every year at 2 or 3 of the national meetings, that's an exceptional person. So these are the kind of applicants that we're dealing with right now.
Yeah, I think I want to echo some of those points. If I think about the international medical graduates we've had in our residency program, you know, most of them have come through and overcome obstacles, hurdles that many of our U.S. graduates wouldn't even consider in terms of life challenges, in terms of competition for educational spots in their own countries, things like that. I think one of the things we struggle with is, you know, do we know the educational programs? So, for example, if I have somebody from a U.S. school, I have a reasonable understanding now that I've been a program director for 15 years what the differences are between these various medical schools. You know, you read a dean's letter, it doesn't really tell you anything anymore, and that sort of thing. So letters of recommendation from people that, you know, are known in the various surgical communities, et cetera. It's not true. You know, somebody may have gone to the very best school in India, but, you know, that's not something I'm familiar with. Or somebody has gone to one of the top schools in Mexico, but I don't really know anything about that program. And so a lot of times what we find is when we have faculty, and it might be true as well for you, who have ties to certain countries, then we tend to be more likely to recruit people from those countries because we have somebody who can vet what sort of education. Plus, you know, they know people in that country, and then that person tends to be targeted towards us. So, for example, we've got a couple of faculty members who did their medical school training in Israel. One of them is the chief of transplant surgery, Yigal Kam. So we get a fair amount of interest from people who have trained in Israeli medical schools, and you know, they tend to be people who have had good training. And they have obviously life experiences in terms of trauma and things like that with suicide bombings that, bring something to our program. I think there's a lot of political push to not hire international graduates now because every medical school has cranked out 40 additional graduates over the concept that there is a shortage of doctors, which actually there's a shortage of primary care, but all 40 of these new graduates aren't going into primary care. So everything has been ratcheted up. So now, surgery is becoming competitive like ortho. Ortho is becoming competitive like ophthalmology. And I suppose ophthalmology is like getting in the NBA or something. And so, you start having your father planning the endowed chair for the ophthalmology department when you're like a second-year student, so you can get in. But and that has increased the competition, and there's a lot of political will amongst all these deans to make sure all of their graduates get jobs. And so, I think that as you look at rules and things like that, they're more designed to make it more difficult for foreign medical grads because that's going to help U.S. grads. And the deans, from their LCME accreditation, if they have students who can't get jobs, that reflects badly on them. And so there's a huge inertia to make sure that we hire all the U.S. grads first. But there's a lot of great foreign medical graduates, and the ones that we've had, their life stories are very compelling. Their work ethic is amazing. They're often, having to deal with family issues. I noticed that some of Guillermo's comments were related to family, and that's another thing that they tend to have a major focus is that they're often older, as you say. They have kids that are in school. Most of my residents, when they have kids, they're like in the feed and watering stage. So, the residents may remember how horrible it was, but the kids aren't going to have any memory because you don't have your first memory till you're like 5. But when your kids are, 12 or 13, they actually have an opinion. And that opinion might be that I don't want to switch schools every other year. And so, it tends to be much more stressful for them. So they're balancing a lot of things that our average U.S. graduates aren't.
So 2 other stigmas that I thought I'd talk about is that one thing I've heard before is that we don't take international graduates because if we do, that Medicare and Medicaid won't pay for that graduate, so we're actually losing money, so we don't really want to do that. And actually corresponded directly with the director of that area of Medicare and Medicaid, and actually that's not accurate. So if for whatever reason that was a concern you had, they will pay a certain number of heads per medical institution depending on what they got approved for. And the only thing that'll hurt you is whether or not they had previous PGY training in their parent institution. So if you do hire somebody who's already done their 4 years of general surgery, then you will get paid 50% of whatever it was. So if you get someone straight out of medical school, it doesn't change anything with the payment. But another thing...
Well, most big programs are over the cap anyway.
Yeah.
So.
But what I'm saying is being international doesn't necessarily hurt you. Yes, ma'am.
And I was just going to echo what Warren said, is that most programs already have their formula from CMS and it's established back in 1997 with the Balanced Budget Act.
Right.
And anything over that probably doesn't actually touch what your original formula was.
Mm-hmm.
And
Doesn't matter, as you were saying.
Yeah.
No,
most hospitals know they're getting their money's worth out of a surgical resident or a fellow. I mean, it's not like, you're doing some clinic every other week and you're spending most of your time in an NIH grant-funded lab and the hospital's paying your salary like a medicine subspecialty. No offense to anybody who might be a medicine subspecialty, but that's true. But they know a surgical person is going to pay for themselves.
Yeah.
So they usually don't have a problem for it because, it's a lot cheaper than a PA or an NP.
Dr. Tassiopoulos, being that you're in...
I have,
go ahead.
Make a comment on what Mark just said, is we're facing, and that's not for foreign medical graduates, but we're facing a new stress now, in our training programs. Our institution has started not funding the fellowships anymore. So essentially, they will fund 50% of the fellow's salary, but they want you to find the other 50% from elsewhere. And that is becoming a problem. They have no problem of funding the residency program, but when it comes to fellowship, they're giving us always a hard time in terms of funding the fellow. They consider the fellow sort of not a good investment for the hospital. They consider that the fellow is more likely to help you individually rather than the institution itself, although for our vascular fellowship it's not true. But that's the new era.
Wow. What about language? Language is always a stigma. My personal feeling is that you can't be surprised that you don't understand the person you hired unless you didn't interview them in the first place and you got them in the match or as an afterthought or something like that. But outside of actually speaking to the person before you hire them, is language something that is a stigma for IMG?
Well, I think in general, you're interviewing people, so they're speaking like we're speaking now. You're able to evaluate it, but that's not the language they're going to be speaking. The language they're going to be speaking is some nurse calling them with like 14 abbreviations and slang and different accents and all this sort of stuff on some phone conversation and expecting you to give them an answer in like 2.2 seconds so they can go back and take care of 15 patients. And that's much more difficult. I think people have a much more difficult understanding because the abbreviations we use in this country can be completely different than what they're used to in their country of origin. You've got different, we sort of think that everybody speaks English, but I think if you go to different parts of the country, it's completely different in terms of intonation, in terms of, meaning of things, et cetera. And so I think that there is some of that becomes an issue. And that's sort of probably just learning the street smarts of it all. And where I found that to be the biggest issue is when you have somebody who hasn't done something clinical for a while and then comes back to do something clinical. Because there's, you've got our EMR systems that are all different and various smart phrases and other sorts of things that are all different. And so, just being able to document care for somebody is an elaborate video game in our current medical institution. And so just getting people up to speed on that can be much more daunting than just having a conversation like we're having.
I agree with you. I think that the majority of us who learn English outside the U.S. will learn English by the book. I'll give you a personal story. My first trip to the U.S. is in July of 1992, and I landed on July 4th weekend, and I had a great flight with Lufthansa to Dallas, but then I had to take a local flight from Dallas to Houston. And on the plane, the flight attendant says something, I have no idea what she's saying. I was like,
You don't speak fluent Houston?
that can be good. And then my first day in cafeteria, I have to say, that it was a really tough day, because I could not make one thing of what was said. But linguistics are an interesting thing. Imagine being from the deep south and trying to make it in Boston. I don't think that's going to take you very far, but within a few weeks or months, you'll get adjusted to it. The problem is the everyday medical lingo, and I still struggle with some of the abbreviations that my residents have formed now in the era of texting, because I get this text message and I say, what is he talking about? So it is part of the game, and you get used to it, and it takes a few weeks or a few months to use it. As a matter of fact, I'll go back to my Baylor experience, because the students there had developed a little booklet, which I still have, which is called Medical Abbreviations. It was a 16-page little booklet you carried in your pocket, and it had every abbreviation that was used in everyday life. And that's something that apparently was there to solve a problem. And it was very useful. You would get that on your orientation at the international office, and it was great.
Yeah, before I came to the United States, so despite speaking English, I would watch the TV show ER over and over, and I would listen as they would start rattling off, all this sort of stuff, because a lot of the words might be just a little bit different or backwards in Spanish than in English, and that, believe it or not, ER was useful for one thing. It helped me. So, yes, sir.
I was just going to say,
Oh.
this issue with language goes back to medical students, my institution, who were first generation in the United States, and accents can be very heavy, and they're incredibly book smart. They do great, but when they get to the third year, the standardized patients and things like that, it's a
So what is the largest sort of hurdle that you've had to overcome with someone who's an international graduate? What was it, and how did you get over it, Doctor?
I did not necessarily have to overcome anything significant at the work
Right.
on work grounds, but I will give you a couple of stories. One is 2 years after graduated Loyola, the fellow there, who is a great vascular surgeon in the U.S. now, had his first child, so he went back to his home country to have his child baptized, and it was the post 9/11 era, and his name was exactly the same with somebody who was on the Homeland Security watch list. So it took him 4 months to come back. These are some of the issues, that you have to face. The most awkward, so to speak, problems are problems that are a little cultural. And it has to do with how some of the people perceive criticism. In some cultures, direct criticism is not very well received. And once you understand the route of communication that you have to take for these people, they respond very well, but they may not respond on a little bit of a direct style like we use a lot of times either in the operating room or on rounds. So being cognizant and a little sensitive about that takes you a long way. But there are some unique problems that have to do essentially with length of training. One of our graduate in general surgery residents right now is a foreign medical graduate. He has a fellowship for vascular surgery at the Cleveland Clinic. But he did a 6-year course in his general surgery residency, which takes him 1 year beyond the 7-year limit that ECFMG sponsors. So he had to take, after he met, with the help of Cleveland Clinic, a process that lasted literally 10 months before he was granted an extension. So imagine being a program director and having to wait until the ECFMG makes its final decision. Usually the decision is favorable, but where does it put you and your program when you're trying to schedule your next year's rotations, waiting for that answer? Those are some unique problems that come with that process.
Yeah, I would agree. It's an extra layer of bureaucracy to deal with the ECFMG. You have visa issues, so depending on what they are, sometimes people have to go back to their country of origin to renew them. We've had that before where, we had to schedule somebody their vacation the very first part of every year because she had to go back to Ecuador to renew her visa. Cultural things, so I agree completely with the criticism. Sometimes there's, people aren't used to like female authority figures. That's something that, in certain countries they're not used to dealing with, and so, when there's a perception when you have, senior residents working with them, they're the female that, they're not used to having somebody, criticize them or telling them and, what you need to do, and that can occasionally be an issue. I think for a place like Denver, we've had issues in terms of, we don't. I'm told we don't have very good Indian food restaurants in Denver, for example. Or you call this Korean barbecue. What's going on? And so there's that. I think there's family-related things. So, for example, we have one of our residents. He's married, and his wife has an internal medicine position after graduating. But because of their situation, she has to go to an underserved area. And they have 2 children that are like 9 and 12. And so he's trying to be a father to his boys, and yet he has to drive out like 2 hours from Denver every weekend when he's not on call to spend time with them because that was the job that she was allowed to get once she finished. And so just some unique things like that. And trying to make sure that they're integrating into your program And we have a pretty good track record of that because we have, a mass number of international people. I have found one thing that everyone bonds with all over the world, and that's soccer. So there's this great book called How Soccer Explains the World. And, it's only about 200 pages, but it just talks about soccer and culturalism and tribalism and things like that and how people become adamant fans. And now that the World Cup's coming, we're going to have a bunch of World Cup parties at my house, apparently. And so, and it's a great opportunity because, we've got a couple of residents from Ghana, and apparently they beat the U.S. every year in the World Cup. And so, I think that that's something that I found, I found sports is a great way to bond with people. And I didn't know much about soccer, but now having international people, I actually have like a little link on my website. So I'll pick up little things like, I was busting the chops of one of our residents from Mexico about the fact that the Mexican coach demanded that the World Cup team be celibate during the World Cup because it was more focused. I'm like, really? You're going to Brazil? What's going on? And so just little things like that, and it allows people to feel like they're, sort of part of what's going on because they don't know that much about U.S. sports, but you start bringing up soccer, and then all of a sudden eyes light up and everybody's interested. So,
sorry, sir.
It helps that the NBA is going,
No, that's another one. The NBA is a huge international too.
So just to wind up, could you give us some sort of highlights as far as what are the positives? So with all the difficulties and all these sort of things, what are the positives to have international graduates? We have 1 or 2 minutes left.
I think that I will agree with Mark 100%. You're hiring some people who are very, very driven, very bright. For them to make the transition from their own country to here, that means that you have overcome a lot of hurdles that the medical students here do not have. And I will give you just an anecdote. In the past 4 years in our institution, the top 75% of the upside scores are by foreign medical graduates. And I think that that's the new trend that we see.
Yeah, they're amazingly hardworking, and they are so grateful when you help them. I mean, it's a very, very positive thing when you've helped somebody who's gone through all that because I just you always remember those moments.
Thank you very much. We'll go to the next session.
Yes, thank you. That was an excellent session. I do actually have one last question for you. Is your hospital have issues with visas? It seems like when we try to hire international medical grads that we are immediately told they have a visa, we don't want to deal with visa problems, and that's more on an administrative hospital side. Do you have those issues, and if you do, how do you deal with that?
In my institution, it's something that, yes, people don't want to deal with it, but there is a certain formula that needs to be followed, and they know exactly what the formula is. And yes, there is a lot of paperwork, but there's no secret to how to do that.
Yeah, I think there's certain visas where if you were to terminate the contract, that the institution would be responsible for relocating the person back to their country of origin, which has some cost associated with it. I know that that's been something that gets mentioned. Otherwise, you just have to start learning about the visas, and there's somebody in your institution who has that responsibility. And I think the more you do it, then people become less frightened of it. I think that what happens is it's just another bureaucratic thing, and if your institution hasn't done much of it, they're resistant to moving forward on that level.
Okay, again, thank you very much for a great session, and please stay up here because I think you'll have a lot of insight into our next session. I just wanted to take this moment to thank everybody for coming on behalf of the Diversity and Inclusion Committee. We have a great turnout, and I know it's early in the morning. The whole goal of this is really to have a lot of audience participation, so please feel free to ask questions, and we really want this to be an interactive session. So next, what we're going to talk about is how to successfully change xenophobia into cultural diversity and understanding. And for that, Dr. Fernando Joglar from University of Puerto Rico and Ageliki Vouyouka from Mount Sinai Hospital are going to help us facilitate that session. Thank you.
Thank you, Robin. And to help us along and improve our understanding and maybe gain some insight into the challenges and barriers to try to promote diversity in our institutions and help us a little bit with our patient encounters, we have three great speakers. And first, I'd like to introduce Dr. Jonathan Woodson, he was one of my attendings at the Boston University Vascular Surgery program, but he's also was assistant Dean for Minority Affairs at that institution. Not only that, he's a board-certified internal medicine, vascular surgery, trauma critical care, and general surgery, a quadruple threat, and a brigadier general in the U.S. Army Reserve. He was assistant surgeon general, and now currently he's in Washington, D.C. as assistant secretary of defense for healthcare affairs. So he's basically in charge of all the medical issues for the armed forces. And I'd like to invite him to share some comments and insights about his current position.
Well, good morning, and thank you so much for the invitation to be here today. This session is on diversity, and diversity has many dimensions. It is about gender and ethics. It's about diversity of thought. It's about diversity of experience. And so I'm going to try and just a very few minutes kind of blend that into sort of a context that I hope will be useful, particularly for the young people in the audience in terms of looking forward in their careers. So if you look at human beings, we're basically social animals, right? We get together in our families, we get together in our tribes, we get together in our nationalities, in our countries. It's a source of protection, pride. It's the way we promote ourselves. And we tend, by that grouping, to be exclusionary. So if you're in the tribe, it's good. If you're outside the tribe, it's not so good. And if we've got resources within our tribe or in our country, we want to protect those resources and not necessarily share if it becomes a survival factor with others. We can extend that kind of analogy to our professions, right? Surgeons are good, internists are bad. I'm conflicted myself because I've been in both worlds, right? And it goes on and on and on like that. Why am I bringing this up? Well, the first thing is that you've got to be aware of that. You've got to be aware of your own biases first. If you, in fact, are going to be able to deal in a diverse society in a diverse set of situations effectively. Now, the good news for most of you is that there have been marked gains in terms of the issue of diversity in this country. When I came along, of course, I was one of one, and I see an old friend in the audience that understands very clearly what it was like 3 decades ago or more decades ago. And for many of the women in the audience who have come up, you understand what it's been like to be one of a few. But now, of course, 50% of classes are women, and just by sheer numbers, you will make an impact, and you have made a very great impact. To bring into sort of this story, my military experience, there was D-Day was just 2 days ago, and in fact, I was supposed to be in Normandy for that. That's a little bit of a different story, but I was reflecting on my dad, who is now deceased. But the fact that when I told him I was going to go into the military, he had this glazed over look in his eyes, and I thought he was really upset with me for that decision. But it turned out, make a long story short, he was just amazed and shocked that I was being assessed into the military, commissioned into the military as a captain, when he had served in World War II in a segregated military service and could not have expected to have risen beyond the rank, really, of sergeant. He had white officers over all of the African-American troops who continuously actually persecuted them even though they were in service to the nation. Of course, in 1947, Truman desegregated the service to the admonition of a lot of our political leaders and even our military leaders that was going to ruin the American forces, and of course that's not true. Fast forward recently in my tenure in Washington as the Assistant Secretary of Defense for Health Affairs, where I am the principal advisor to the Secretary of Defense and to the President by extension for all matters related to military health. We've accomplished some things in the recent years, and I do mean that the global we, that heretofore was not expected. So, of course, Don't Ask, Don't Tell went away, right? Gays can openly serve in the military, and oh, by the way, they had been serving in very important positions and contributing greatly. We've opened up all of the positions to women so that if they so desire, they can compete for any position in the military. And as a result, we have, in fact, pushed that envelope of inclusion, if you will, quite aggressively, even at a time when we've been at war. And social experimenting, some would believe, with the military when you're at war is a risky endeavor. But the point I'm making is that diversity, we've learned, is really a force multiplier. It's about using everybody's talent to their best advantage and to their greatest potential. The things I've learned in my position, in my various positions, right now, of course, I have responsibility for international relations. I travel all over the world. In fact, I just got back from South Africa a couple of days ago. I find that this issue of diversity and understanding other people and the way other people think really is a multiplier, because when you have difficult solutions, if you have groupthink, you don't get to the true answers. And when you have, when you can lead diverse groups in terms of thought, gender, ethnicity, disciplines, that's when you get to truer answers to difficult problems. But for all of you, the other dimension, and I'll close on this because there are other speakers, you have to understand that you need a diversity of experiences in order to build your toolkit. You need to understand your own biases, because otherwise you'll close the door to interacting with people who might otherwise help you. So throughout the course of your lives and your careers, you're going to need mentors. And if you cannot, in fact, interact with women if you're a man, or a man if you're a woman, or with gays if you're straight, or you name it, you will close off opportunities to gain knowledge and assistance with your careers as you go through. And then the last piece is, as you mature in your careers and you become leaders, you will absolutely need to understand the power of diversity to bring the most effective people together, to set the stage to advance your discipline, advance your organization, advance your strategy for the future. So that's a lot in a few minutes, but I hope it sets the stage for an in-depth discussion to follow. So thank you very much for inviting me here today.
So we're going to change gears a little bit now. The next speaker is Dr. Anil Hingorani. He's a very brilliant academic surgeon, but he also has a very large practice in Brooklyn. He's a vascular surgeon at Lutherans Hospital, and he takes care of a very diverse community. And he's going to talk to us about challenges in overcoming diversity, biases and cultural biases when you take care of patients. And when it comes in taking care of patients, the challenges are even more significant, because usually
it's not only the physician who has to understand the patient and the background and how he perceives or she perceives disease and symptoms, but she also has, the patient actually has to surpass his own biases, when it comes to his physicians. Anil will explain that, but there are patients from different communities that they perceive different, a young person or an older person, female or a male, and the physician has to try a lot to overcome all these biases and make the patient trust him, so the communication, the relationship is effective towards healing him and taking care of his disease.
I want to thank you very much. This sounds like a very exciting session. I decided to take a little slightly different approach and try to make it a little more personal with some experiences that I've had over the last couple of years of working in New York, which tends to deal with diversity issues every day. So this is a patient who's been a patient in our office for a number of years. He's a 70-year-old morbidly obese, morbidly obese male who comes in with to the office with leaking venous stasis ulcers with a large pool of serous fluid on the floor routinely. They're not infected, and he comes in here for his weekly Unibut. Of course, he's refused any endovenous therapy to help correct this problem, but nonetheless, he does come in pretty regularly. This time, after he's examined by myself, he's wrapped up with his Unibut by the medical assistant. However, this time I'm sitting at the station, and he comes out of the room, and he gives me a quarter. And he says, "Here's a quarter for your camel you have parked out on the front curb." First, I didn't understand what he was saying. I thought I'd misheard him. So after I didn't respond, he repeated the same statement again. "Here's a quarter for your camel." The camel you have outside parked out on the front curb. I clearly understood what he was saying this time, but I didn't answer. He had this weird smirk, and he left. Next week, the exact same scenario happens again. And I responded the same way. I just smiled, and he left. Good point. That would have been a good point. I didn't think of that. So after the patient leaves, the medical assistant who was there for both episodes comes up to me, and he's quite indignant. He's young, a Russian gentleman. He is asking me, "Why didn't you respond to that SOB? These were obviously quite racist." I didn't really know what to say. So I had a couple of options. One, I could just wait for it to happen again and then confront the patient. I could not wait and just try to chase him down while he was waiting out in the front waiting area, waiting for his Accessoride to go home and confront him. Or, again, I could just do nothing and let it pass. So I explained to the medical assistant, who doesn't understand why I didn't say anything, that quite frankly, I've been dealing with these issues with the color of my skin for 47 years, and I'm not going to be able to change this 70-year-old male or the color of my skin. He was okay with that. However, the next time the patient came into the clinic, but this time I offered him a quarter for his camel parked out in the curb, but I didn't attack him. I just said it with a smile. For the last 18 months, there have been no more discussions of camels. His ulcers are still open, and he's still refusing any other therapy or change in his wound care. What did we learn from this? You can confront these patients when you feel that there may be a problem, but you can also do it without aggression. There are several ways of approaching these types of problems. And sometimes fighting, in this term the MA felt to as bigotry, means building trust. Sometimes you have to slow down, which doesn't come very easy for vascular surgeons often, I understand that, but having patience with these patients and understanding can actually crack it. This is another young patient who was referred, a 30-year-old Muslim patient, who was referred to our office for lower extremity varicose veins. Her husband is in the room at the beginning of the evaluation, standing by the examining table. Any question I ask, he answers. Even if I'm directly looking at her and asking her what I thought would be questions that she would only be able to answer, he would go ahead and ask her and give the answer. When I try to examine the patient, he says, no, I do have a female physician. So what options do I have? Well, later, after this, I'd seen this patient, we actually did hire a female physician. That would have been one alternative, but at this point in time, we did not have another female physician. We were all males. Any suggestions from the audience about what suggestions for this? Is a Muslim patient. They are clearly quite religious and orthodox in their traditions. What other options would I possibly have? Ruth? The tables could be reversed. It could be a male patient who's...
I think for men, this is a little bit more challenging, and I think one of your options is what the general surgeons that I see do is bring in a chaperone. And I think that, you may not have a female physician.
That's one thing that I've used also, is have the MA, some of them are female, come in and... Sometimes it is, sometimes it isn't. It depends on how you approach it. Sometimes I ask the husband if it's okay if the MA comes in who is female, or at least I try to explain that I'm just going to be looking at the legs, palpate the abdomen, listen to the chest and abdomen, and sometimes by explaining it, what I'm going to be doing, sometimes that's enough, with focus on looking at her varicose veins. That has helped sometimes. Sometimes they have to be rescheduled for another day when we have someone else there. So again, taking it step by step, taking it slow with the husband and the patient can help. But taking the time to appreciate the problem is sometimes half the battle. And again, half of the battle, sometimes dealing with these cultural differences, being first familiar, acknowledging these problems, these differences, and respecting them, and then trying to accommodate by presenting different solutions to the family. Sometimes they'll pick one. Sometimes they'll say, no, I'll reschedule. I come into the room. At this point, earlier, I would just finish fellowship, and I've been always taught when you come into the room, you introduce yourself, you hold your hand out, and before you do the history and physical, you hold your hand out to greet them. And I held my hand out to greet an 84-year-old Jewish Orthodox female. She immediately informs me that her traditions do not allow her to shake my hand. I felt somewhat awkward because I had only done this several hundred times in the last year, and it sort of tripped me up. It sort of interrupted my flow. So I was like, okay, this is not going so well. I need to try again. I examine her, speak to her, get a duplex, and it was clear based on physical exam that her leg was acutely ischemic and she needed urgent revascularization. So I suggested an immediate admission and urgent revascularization. She declines. I try to explain the urgency to her, and she says, no, I'm not going to go for this. I explain the risks of limb loss, pain, suffering, morbidity, mortality, and she says no. I've finally given up, and I've said, okay, I've tried everything. I'm going to have to document everything in the chart, and just to CYA, and I've tried everything I can try. As I start to leave the room, she states that she needs to discuss her case with her rabbi. I'd forgotten one major point. I forgot to explore the reasons why she was declining. This was Friday afternoon. She had come in with an acutely ischemic limb. It was her religious time when she's not supposed to be doing any procedures, specifically including operative procedures, unless it's cleared by her religious figure. I failed to take into take into consideration that this patient's family and or religious figures overruled what I would say as a physician, even though I felt that I was the expert in this field. So in the Jewish tradition, the rabbi may have a very important role even in medical decisions. And I also failed to take into consideration that this was their Shabbos, this is their Sabbath, this is their time when they're not supposed to be having any procedures. They're not supposed to be cooking. They're not supposed to be turning on the light switch, because this is a time of religious worship, a time of rest, and a religious time where they're not allowed to do any of these. So if I were to break these traditions, I would have to go to the rabbi first and discuss this. Having an ego dealing with rabbis who I felt had no consideration of this type of urgency, it took me a while to get used to that I would have to incorporate someone who I felt was not capable of evaluating the urgency of this procedure, but I found I was wrong. The rabbis deal with this every day. They deal with these types of issues with urgent procedures that need to be done during Shabbos, or urgent procedures that need to be done even without Shabbos, and they can also be your allies. So taking into consideration the family, the mother, the father, the son, the daughter, whatever the tradition is with that family, can play an important role in some cultures. And I think I learned a lot from this. Now, having since then, I've dealt with a lot of rabbis, and I know a lot of them fairly well. And they've come to trust me, saying that this needs to go now, despite religious or practice or other blockades. And over the years, that's become less of an issue. So some of the tricks, again, understanding the culture. Sometimes I find that if I can speak a little bit of the language, although my Hindi is not so great and my Urdu is not that great, the patients feel that if I can speak a little bit of their language, a little bit of Spanish, a little Italian, a little Portuguese, it really goes a long way. You've made the first attempt. You've made the attempt to understand their culture, their religion, and their tradition. One of the most potent ways that I've gotten around with the rabbis is demonstrating medical excellence. By continuing to work with the patients, even if they say no, continuing to work with them with, as we all do, with whatever surgical expertise or non-surgical expertise, they do learn to trust you. And you do gain bonds with these communities, and that can actually help you quite a bit. Finally, one of our new partners was from Rome. Very well trained, very, very well spoken, and an excellent surgeon. Initially, we had a large portion of patients who only spoke Italian. And I thought when we were hiring her, this would be a great way to facilitate their care. Before, we either didn't have translators, or I would try to speak in Spanish and hope that they understood me, or we would try to, if we happened to have the secretary that day who spoke Italian, have her come into the room. Didn't always work so well. When I brought this up with her, that this would be a great way that you'd be able to link up with this community, she responded to me more than slightly upset that the Italian males that she was seeing see her as a nurse and cannot imagine that she's actually their surgeon, their physician, the one who's going to be in charge of their care. I didn't understand the Italian, obviously, and she specifically stated that they would routinely denigrate her in front of the family. So I was trying to figure out, what can we do for this type of situation? Robin, I guess you've dealt with these issues before also. How would you deal with this type of situation? It's clearly cultural. It's clearly a problem that we need to deal with, because about a third of our patients are Italian, and a good portion of them don't speak English. And some of them come in with no translators.
Yeah, I mean, I think we deal with this. This is actually going to be our next session, is if gender really is still an issue. And I think it is, as a woman, and I also work at the VA, where you're constantly dealing with men that kind of look at you, or look at the male medical student behind you and think that they're actually the surgeon, you must be their assistant. But I think if your medical knowledge eventually wins over these people. And I think if you demonstrate your expertise and your medical knowledge, and again, because we're surgeons, I think we just try to quickly move past these issues and just get to the medical issues and kind of ignore it. I think we could do a better job acknowledging it and then stating, these are my credentials, and moving on to the medical problem. But I think this issue is going to be addressed in our next session a little bit more, but that's usually how I deal with it.
I totally agree. Eventually, with her excellent results, repeatedly, she was able to overcome some of these with the Italian patients, and some of the private Italian patients do come to see her only, not the male physicians who are there, and she actually overcame that directly with what you're saying. But I think there's a variety of different tools that you need to use. I hope that some of these case scenarios were able to exemplify some of those different techniques that I've tried, and sometimes they can be quite helpful in difficult situations. Thank you. Any questions?
Thank you, Dr. Hingorani. I had the privilege of working with Dr. Hingorani when I was an intern, and he's probably dealt with more, these cultural situations than anybody I know. My question is, for the other people on the panel, in your home programs, if they're not in Brooklyn, New York, where it's this culturally diverse, what actual opportunities do they have to interact with patients like this? Because you can talk about it and you can say, this is the type of interaction you will have, but until you actually experience it, it's really difficult to understand how to overcome it.
Well, I think in Denver, we have a lot of experience with Hispanic population, but much less volume with the other issues that he was describing. I mean, we see them once in a while, but not tremendously frequent. So you're not going to get the same level of cultural experience probably than you would if you were in his clinic. And I think that's just part of learning the practice, and coming out, and you're going to have to, you're not going to be the finished product when you graduate, and so depending on where you're going to be, you're going to have to learn some of these things after training. You can use simulation and other sorts of things, but it's not going to be the same as what he just went through. There's just no way.
There are some good practice resources also. JAMA has a few articles looking at these specific issues. I know as vascular surgeons we don't always look at JAMA, but they do have a series of articles looking at these specific types of issues. Most of them are editorials though, and they have some case scenarios looking at issues and how some of the alternatives for dealing with them, because this field really doesn't only exclude itself from just cultural problems, but also expands into some of the ethics, because sometimes there can be ethical problems also. Yes?
I think one of the ways of dealing with the office also is that you have to set the expectation. If you have two people walking in the room, and it's an Italian male, and you have a young female, and a male medical assistant, and no expectation for that it's not going to be different than what he expected, you're going to get an expected result. So if you have from the beginning your office staff introducing the person, discussing the patient, you're going to see you may at least start the conversation, and so you don't surprise the patient, which then puts them off and they react in a defensive manner.
Absolutely. I think the expectations, playing off the other expectations, plays an important role. Thank you.
Thank you, Dr. Hingorani. And before we wrap up, we have Dr. Luis Sanchez, who's a fellow Puerto Rican. He went to medical school here in Boston at Harvard Medical School, did his surgery training, vascular surgery training at the Montefiore Medical Center in New York. And I'd like to invite him to share some comments. He's got a very diverse group of vascular surgeons at Washington University, St. Louis, Barnes-Jewish Hospital. So I'd like him to share some of his insights.
Thanks, and obviously we need to get moving to the next session. You heard a lot about sort of diversity and trying to work with a variety of patients. With my experience in New York, it was somewhat similar at Anil's, but I had more of a Spanish population, which made it easy for me just to have clinic in Spanish in the Bronx. But just as important as dealing with the patients and the patient populations that you may encounter, you have to deal with some of your colleagues and some of the other people in the medical center and the communities that you live in. That's going to end up being as much of an issue for some of you practicing in the different places as much as the patients that you're going to be treating. You have to be able to recognize some of the biases that can occur, and a lot of it is perceived. It's not even real, but it's the perception that they have and you have related to the interactions that you will have at work, with patients, and even within your community. We have a very diverse community in our medical center, but it's very different in the community around St. Louis, which is not quite as diverse as the communities in Brooklyn or in the Bronx where I trained. And it takes sometimes a little bit to be able to fit in the communities and for everybody to recognize, your expertise, where you come from, and where you fit in that community, and what the value that you bring to it. A lot of the people will have questions initially, but as you bring in your knowledge and your expertise, then most of them will just open up and be able to work with you very well. So there are two different sides. You heard a little bit about, and in detail, about what you have to deal with patient populations that are changing and becoming much more diverse around the United States, but you have to also keep in mind all the people that work with you in the medical center and the people around the community, how they see you and how you recognize them, how you see them. You may have some biases that, even from your own background, may affect how you address them, and you have to sort of think about them before you try to have some of these interactions to make them the best possible. I hope you enjoy the session.
Okay, I think we have time for just one last question, and then we'll move on to our last topic. So I know we had still some hands up in the audience. Is there one last question we want to ask?
My name is David. I'm a general surgery going into vascular. One of the questions that I have is, a surgeon was told me recently, from a legal perspective, one of the worst situations you find yourself is to find yourself with a patient, for whatever reason, due to their background, do not want you taken care of. And we just talked about a series of patients here where they're kind of refusing your care because of some kind of underlying belief or some background. When do you make that decision that you want to push a little further and try to convince them that what you're about to do to them is to save their life or their legs? Or when do you say to yourself, this is not a situation that I want to find myself? Because if you end up taking care of a patient that almost truly do not want you to take care of them, for whatever reason that might be, I see that being a major problem down the line, because everything that you do from that point onward, if it's not criticized by the patient, it's probably going to be criticized by the family. Is that something that, when do you draw the line? When do you say to yourself, okay, I have done the best that I can to explain and to understand that, to make them understand what I'm saying, and I need to go find somebody now because we can't get along. When do you stop? When do you keep going?
I can.
That's an excellent question, and let me just give you a quick vignette. We're in Boston. Boston, a few decades ago, was not the bastion of diversity and openness. I'm in the emergency room, and we get someone in from South Boston, and he had been injured, and he looks up at me and he says, no offense, doc, but I don't want any black doctor taking care of me. I thought it was kind of funny because here he was bleeding, and the thought that he had really a choice in that situation was open to question. But at any rate, the point I want to make is you will run across these issues occasionally, depending on the communities in which you work. And I think the key is to, number one, not get overly offended by it, but have arrangements with partners and the like to transfer the care. Because fundamentally what we do is about trust. And it will color everything. Sometimes you can win people over, and I've had a number of those situations. But if it's clear that the nature of the interaction is going to be adversarial because of the biases, then I think you make those arrangements with your colleagues and transfer the care.
Why don't we take one last comment? Angeliki?
Yeah, I agree with you because I also, something I will never forget, I had a patient who was very traditional Pakistani gentleman, came with his wife, with his daughter actually. He wasn't speaking English. He had 2 TIAs. He had a severe carotid stenosis. And I wanted to do his case. I kept talking to the daughter. He didn't participate at the discussion. He made some weird comments, who's going to put my folate during the case? And do you have a urologist? And do you have a guy? But never really discussed. I knew at some point, deep in my heart, I knew that he didn't want a female surgeon. But I just wanted to do the case. I tried to be persuasive. And the guy canceled his procedure twice, and he stroked out. Eventually, he had endarterectomy by somebody else, but now the patient comes first, and he's sick, he's old. I don't think we can try to change his mentality. If he looks like he has something very severe, that there's no time to discuss and philosophize and figure out who's supposed to do the surgery, I think he should go and have the surgery with whoever he feels more comfortable with.
Ruth? Yes, Vanita.
For the most part, I think you have to try to maintain the integrity of your educational system, and so at least at UC Denver, we've tried to be pretty upfront with the patients. Like, these are the residents; they're going to be participating in your care. We don't want to set a precedent where you're not going to be doing this, you're not going to be doing that. But every now and then it becomes something that's sort of a deal breaker. But I think for the most part, our attendings try to negotiate those issues for the residents, and not always successfully. But it's sort of like the culture you're trying to have, where you don't have a 2 different types of standards or multiple different rules of engagement. Just because I think from an educational integrity standpoint, it becomes a problem.
Okay, I think we have one last comment from Dr. Woodson, and then we're going to transition to our last topic.
Yeah, thanks very much for that question. I think that the attending needs to take on the responsibility of interceding and really having a detailed discussion with the patient and making them understand about the arrangements for hospital, for safe care, for team care, and the like. However, if the patient doesn't buy it, it goes back to my original comment that since these are increasingly more rare kinds of events, you manage around that kind of situation, and you protect the resident, you protect the team, the hospital, and you transfer the care to other residents.
Thank you very much, all of the speakers, and for all of your comments. I think this is a great topic, and I think we've learned for next year we can probably pick one topic and talk for an hour and a half. I just wanted to transition to our last topic, and that is, of course, about the female gender still. As you know, we've all had our first female president of the SVS, and that medical students, our medical schools are about, or even over 50% female. So our question that we're going to ask here is gender still an issue? So Dr. Shaw is going to go ahead and introduce our speakers.
Good morning. So today, to address this topic, I've actually called upon 2 of my mentors, Dr. Ruth Bush, I've known since I was a graduating fellow, and she took the initiative to come and say hi to me at one of the many meetings we went to at some point. And ever since, I feel, even from afar, we've not even been in the same region, she's always sort of been a mentor to me. And then even more recently, Dr. Vivian Gahtan has been even a more important mentor to me lately now that she's now my boss. So Dr. Bush is currently the interim vice dean at the Bryan College Station and professor of surgery at the Texas A&M Health Science Center College of Medicine. And Dr. Gahtan is the division chief of vascular surgery at SUNY Upstate Medical University in Syracuse, New York. So to help transition about gender biases and barriers for women in leadership, I just was going to run through a few points. They're really true, false, and I think that their talks are going to elucidate these ideas. First would be, my gender does not prevent my promotion academically. My gender may prevent my advancement into leadership positions. Most medical schools foster an environment where women feel accepted and supported. Most women are confident about their chances for advancement. A woman's likelihood of professional advancement is the same amongst institutions and regions. Women do not currently experience discrimination based on gender in academic medicine. Gender does not affect academic rank. Women make up a larger proportion of diplomats in vascular surgery than other surgical specialties, and the same proportion of women choose either a traditional 2-year fellowship or an integrated 5-year residency. And lastly, women are proportionally represented as program directors in vascular surgery. So whether these are true or false, you'll know after both of their talks. Thank you.
Thanks, Palma. Okay. All right, so I'm just going to talk for a couple of minutes about women in academic medicine and where we stand. For the past 10 years in medical schools, women have made up 50% of the matriculating classes. So we have 50% in the classes, so where do they go after that? This is not reflected, and that's the answer to several of Palma's questions. This is not reflected in academic medicine. You can see the numbers here, 35% of all faculty. Usually the women are in junior teaching positions. If you go down the list, which goes higher up in the hierarchy of academic medicine, the numbers get smaller, and 13% of deans, and I suspect that number is much less this past year. It's been published and looked at in a large survey of almost 4,600 full-time faculty at many medical schools across the country about women and barriers in academic medicine. They don't have the same support group. They don't feel like they have a peer group to be with and to be supportive. They're pessimistic about gender equity and chances for advancement, so another no to one of her questions. And they don't believe that institutions are family friendly, and they are less likely to see their values aligning with the institutions. So why have we in academic medicine failed to create an environment for women if they are 50% of the medical students and 35% of the teaching faculty? It's been published again about the cultural barriers in academic medicine, the less support. And in the Journal of General Internal Medicine, a quote is that although men and women working in academic medicine strive towards advancement, significantly fewer women achieve leadership positions. So what do I mean by significantly fewer women? The Association of American Medical Colleges, the AAMC, publishes a statistics on women in academic medicine every 2 years. So this summer we should be getting, or this year we should be getting the last 2 years. So the last report was 2011, 2012. And this is a graph showing women, the distribution in full-time faculty by rank and gender. And the darker blue is men and the lighter blue is women, and you can look at the full professors over to instructors on the right, full professors on the left. The percentage of full-time faculty that are at each level. Again, women tend to be congregated in the lower ranks, so assistant professors, much fewer associate professors, and full professors. I was the first full professor in the Department of Surgery at my institution. And the hospital when I was at Scott and White Hospital in Central Texas, is 135 years old. And I found that interesting, that I was the first full professor in the Department of Surgery, and I was only the fourth at the entire institution, and I was the second tenured professor, female professor. At Texas A&M Health Science Center, those are the AAMC's benchmarks. We fall incredibly below that. So Central Texas, if you want to be promoted, it's a little challenging for women. We have 1,200 total faculty at the College of Medicine. A good portion of those, 351, 29% are women. And this is the women faculty by rank. Regents professor is something that you're nominated by Texas A&M. It's a upper level professor who's been around for a while. I think there's one. Professors, you can see we're at 2%, so or less than 2%, so well below that 5% that the AAMC has published. And then again, most of the women are in the assistant professor. What I don't know is how long they've been at the assistant professor level. And so is this that we're not putting them up for promotion, we're not mentoring them? That's something that we've actually started studying at my institution, being sponsored by my SVS Women's Leadership Grant, which was to look at the women faculty at our institution. So here's our numbers compared to the AAMC numbers. AAMC is in the light blue, and Texas A&M is in the dark blue. So I think we've got a lot of work to do, but what is fabulous is I've got some great people who are looking at this. We've pointed it out. The dean is very aware and wants something done. So we're starting some junior faculty mentoring groups and networking and assistance in putting their promotion packets together. In academic medicine, one of the major journals for those of us who are in educational positions has identified some of the barriers: specialty choice, self-defined career goals, gender bias, the culture of academic medicine where men have been at the top, female attrition rates compared to male colleagues, and is this that women are taking time off for, in their younger years to have children and then coming back? How is that transition? Does the promotion and tenure clock stop when you get pregnant and decide to have a baby? Some places it slows down, some places it does not. But what I want to point out is that we've had tremendous leadership, and I've got a lot of people's footsteps to follow in, and people that I know that I can call up. And one person I left out on here is Melina Kibbe, who is the past president of the Association for Academic Surgery. So we've had a lot of women who have, in recent years, though, risen to be president of multiple societies around the country. And I think any of us would say, call us up, talk to us. We're there to assist you and give you advice. And I've had tremendous mentorship from all of these women. And so now I'm going to turn that over to Dr. Gahtan, who's going to continue the discussion.
Thank you, Ruth, and thank you, Palma. So I'm going to focus on vascular surgery and where we're at. I have nothing to disclose. So when we look at, and Julie did show some of this data presented a little bit differently yesterday, but if you look at board-certified surgeons, those who have passed their oral exam, women make up currently 7.8% of all diplomates. And of those that are currently active, they make up 8.9%. And the other thing is that as we have more women coming into vascular surgery, we have the percentage of diplomates is rising, and it has increased 19% in 2 of the past 3 years. So I think we're going to see a change in these numbers. This is a graphic that shows general surgery and vascular surgery with the trend lines. You can see they actually parallel each other. The light blue line is general surgery diplomates from the board, and the red line is vascular surgery diplomates. So as women are increasingly become board certified in general surgery, we seem to see a similar trend line for vascular as well. This overlaps all ABS diplomats, and 1976 is where we have the start for general surgery. And pediatric surgery starts at the same time. Vascular surgery comes in 1984, hand surgery in 1989, and critical care 1987, I believe. And so they start at different time points. But if you look at all of these, you will notice that vascular surgery seems to fall below them. And if these are average trend lines, we have pretty much at this juncture, pediatric surgery, general surgery, and critical care. In terms of diplomats, women make up about somewhere around 38%, 32, 35%, and vascular surgery is still way down in the low 20s, with hand surgery actually being slightly above it. Now, the hand surgery American Board of Surgery diplomats is a very tiny group. So the trend is in the right place, but clearly of all the different subspecialties that are board certified by the American Board of Surgery, vascular surgery is at the low end, and is the low end. When I switched to just discussing female fellows and integrated residents, the red bar is the integrated residents, and the blue bars are the female fellows, looking at from 2007 through 2013. We can see that there's an upward trend across both of them. But interestingly, where we go in 2007, where we didn't have any women entering the integrated vascular surgery residency programs, by 2011, we were at 40%, and the last 2 years have been at 38%. And that's really been pretty interesting and more proportional to the percent of women that are in medical schools. So at least for the integrated programs, we're seeing something that's a distribution that seems to more fit the population of students that we have. So the fellows are trending in that direction. They're now in the 20s, probably about 23%. And it's a very slow but steady increased trend, and I think it reflects the fact that we have more women entering general surgery. So I think the trend is in an interesting direction. And then the latest information that I have on program directors, there are 108 program directors in vascular surgery. Of those, 7.4% of them are women. And many programs have, in addition, an assistant program director, and of those, women make up 17.5%. And when you consider the percentage of women who are actually diplomats of vascular surgery by the board and the number in academics, these numbers don't seem way off. Yeah. And so I think we meant that to be sort of an entree into a discussion, sort of where we're at with academic medicine and specifically the data that we have on vascular surgery.
So I already listed my 10 true-false before they started. But I wondered if anybody in the audience, if there's any trainees in the audience, do you have any pointed questions for our experts here, guidance or, something that may clarify something for you? Yes.
And there's actually papers published on that. That's a good question. There are papers published on that. And yes, men have traditionally advanced more quickly. You have to think, where do these conversations take place? Where do most conversations take place? They take place in the locker room, okay? And so traditionally for, people in my generation, Dr. Gahtan's generation, sorry, we went in our locker room by ourselves. And where I trained at Emory, the doctor's lounge was actually part of the male locker room. And so I would just barge in there, but that's okay. So yes, they have advanced a little more quickly, and it may be because they've had more mentors who took them under their wing. I think that hopefully will be changing. But yes, they have advanced more quickly. That doesn't mean that that men and women don't have equal credentials to advance. I think it hasn't been something that's been seen as something of importance sometimes to women. It's not there on their priority scale when they're in their, upper 20s, 30s. And it's something I'll do later, whereas the men are sort of taken along, and anyone here can comment on that as well. I just met with an associate professor who's fabulous at our institution, and she's a family practitioner, and she's been teaching and doing our simulation and SP program for forever. And I said, how long have you been an associate professor? And this was about 2 weeks ago. It's been about 12 or 13 years. And I'm like, we're going to put you up and get your package together for full professor. She clearly has the publications, everything. It's just a matter of getting everything and having somebody who is her champion. And so I'm hoping that we can change that trend. And I mean, our numbers are pathetic compared to the AAMC. I at least want to get us close to the national average, because I don't want women to not want to come to my institution because they don't see any career advancement. So that's a long-winded answer. And I'm happy for any of the men to comment on that who've been in academic medicine. I'm seeing.
Yeah, so I'm on the promotion tenure committee at our institution, and it goes for the associate with tenure and professor. And it's about peer-reviewed, high-impact publications at extramural funding at the NIH level, and it's gender neutral.
But is it? What I'm also finding, and I think you're correct in some parts of it being gender neutral, but is that, do we have to go down to the lab level then, Dr. Huber, and are people pushing the men into those high impact things? Yeah. Yeah.
To that point, but when you look at that data, and there's a marked discrepancy between assistants and associates and full professors, but at some level, that's an equal playing field.
Okay. That's good to know.
Well, I think, one issue in terms of promoting your academic career, I always say the most important word in the English language for junior faculty is the word no. Because you've got to start thinking about your career, and everybody is basically dumping on you to do things. And if you really need to get in that mindset of like, I need to protect this piece. And I think it's hard because, there is sort of this feeling, at least when I've mentored some of our junior, female faculty, is that, they're constantly being asked to do things, and they have a hard time saying no to people, and that ends up, not leaving time for some of the other pieces that you're describing, and you just have to carve it out. And sometimes to do that, is not, you're not always going to be friendly about it.
I think, honestly, both men and women are struggling with promotion and going through the traditional system because we all, life balance is different. How we spend our time is different, both clinically and personally, and what we're expected to do at home is different for all of us. And so I think it is more challenging now to have people go through more traditional routes without these other tracks that allow people to actually get promoted. And it is a challenge, but you really have to look at whatever institution you go to, you really have to look at the criteria for promotion, the track you're going to fit, and you need to have a mentor to help you get there to stay on track. And I think it's sometimes it's these mentorship differences and having somebody really understand the system and guide their faculty into the right track that will allow them to grow and prosper is where those discrepancies start to occur. And I think issues like saying yes to the right things and no to the wrong, enough of the wrong things that prevent you from moving forward. Even though you're very busy and making a contribution to your institution, you're not going to get promoted. And I think those things are need to be selective. And it really does come down to a mentor. Somebody who's 2 or 3 years out is not going to know exactly what to say no to, or even if they know they should say no, they don't think they can. Correct. So I think these are some real barriers that are problematic to many faculty, and I think who you have to guide you and how much they advocate for you in that helps guide that faculty person. And it is a little bit more of a struggle, I think, for some women, depending on what that infrastructure is to help them get there.
Anil, I think you had a comment too.
You know, you spent a lot of time identifying the problem, the disconnect between women and men in terms of academic advancement and whatnot. And I didn't think that we mentioned enough of the solution. We focused on mentorship, but I'm not certain that's the only answer. So if I can ask some of the people up here, what other solutions are there? Mentors, I think, play a key role, but mentors don't.
I think Anil is right, and I'll make 2 points. One, I will echo what Vivian said before. When you're accepting a position somewhere, make sure that you understand in that particular institution what it will take for you to go to the next rank. And the first thing that I discuss with faculty that is interviewing with us to take a position is what are the necessary steps that they will need to take to get to the next level. And that's part of their annual evaluation, is like how close are they coming to that goal every year that goes by. And that's something that has to be the responsibility of every person who wants to do that. I think that's part of the solution. And honestly, most of the initiatives towards promoting somebody start with the chief of the division, and that's the key person that you have to design a plan with to get to the next level.
I would echo that, and I appreciate the question, Anil, about what are the solutions, because we definitely identified the problem. I think the mentorship, but you have to make an active, not just say, oh, go find a mentor. So we're starting almost like a women's networking, as well as a junior faculty networking opportunity to get together to talk about, what do I need for promotion, because they often don't know where to go for the answers. And if you don't have a chief, or where I am, I'm the campus vice dean, so this year I did performance evaluations of all of my direct faculty, which was quite a few, and we sat down and I asked them what their goals were. And I came to find out that in all the years that we've had a campus in College Station, I was the first campus vice dean who's ever done that. And I found that it was very appreciated, and that's where we started identifying how I'm going to do this. Some people said, no, I'm happy where I am. But most people were interested, and they want to find out, from the Promotion and Tenure Committee, what exactly are the next steps, but no one had ever addressed it with them. So I think part of it is us as leaders have to be the ones reaching out. We can't just depend on junior faculty.
I think we have one last question from the audience. Vanita?
Associate and full professors, and we just kind of realized this and are trying to understand why and how we can address that. But it was pretty dramatic, particularly on the Secretary. I don't know if you guys have any comments on whether that's something that we're seeing at the national level.
Well, the biggest attrition happens from assistant to associate professor, and at least some years the number of women assistant professors has even been a little bit greater than the number of males.
Because you've got so many junior.
Right.
Yeah.
If you look at these different data sets over time, there's actually was a year where there were more women assistant professors than men. And so I think your biggest attrition is that assistant to associate professor, being able to make that step up in orientation of your career in that direction. And that's a very big challenge. So I think that's a piece of it, but it is those critical early years of knowing what you need to do, having the tools that allow you to do it, and then actually carrying out the work. It's all three of those things where most people are lost. And, I do think mentorship is a piece of it. I think having the resources and being given X number of responsibilities helps somebody also be able to fit it all in and get it done. So the environment that allows you to succeed, and then having the drive to succeed and being willing to put in that extra time, which honestly, that's what it takes, is extra time out of your personal world. Those are all the things that are going to happen. And depending on the institution as well, And it's a lot more flexible than it used to be. You have a set timeline to get to different stages. And if you have a family and you have other things going on in your personal and family world, you may not be able to, or choose that keeping up with that pace is not worthwhile based on your other commitments, versus other places that have more flexibility that may let this happen over 8 years instead of 5, you know. So I think those are some of the factors. It may not be all of them, but I think there's some of them.
I think that's another good comment, though, is that everybody, you know, you see Dr. Freischlag, and you're like, this is the timeline I need to be on, and she's 59 and the president in the SVS. But everybody can be on a different timeline. And I think with women, if you do, you know, take a break when you're having small children and that type of thing, you can get back on the train. And I think that's kind of the issue, is that, you know, it may just be that you're 5 to 10 years behind your male colleagues, but also that that's okay, because you did have a lot more stressors and work at home than maybe your male colleagues had. And I think that's something that women, you can't always just gear yourself towards, well, this person is this age and this is where they're at and I'm not there yet. It may just be a different timeline. Well, I'd like to thank everybody for coming. We had some great speakers and some great conversation. We'll definitely push to do the same session again next year, and we hope that you all come back. But thanks again, everybody, and thank you again, all the speakers. We appreciate everything you had to say. Thank you.